Good morning. My name is Claudia Chambers. I'm an OBGYN. I am an associate professor at Creighton University and the assistant dean of admissions at the Creighton Regional Campus. I am the immediate past chair of OBGYN, and I'm here to share with you about adverse pregnancy outcomes and future cardiovascular risk. I have no disclosures. The objectives of the discussion today is to look at the current state of cardiovascular disease and the impact it has on pregnant and postpartum women, to look at risk factors driving maternal mortality, to understand the impact that racial disparities is having on maternal morbidity and mortality, to describe the recommendations for patient care in the pregnant and postpartum state, as well as understand risk stratification strategies to mitigate maternal mortality. And finally, to understand the value of interdisciplinary care in decreasing poor maternal outcomes. It's important to understand the impact of maternal mortality in the US. The most recent numbers that we have suggest that 17 women per 100,000 die giving birth, and that there are significant gaps that exist in racial and ethnic outcomes. Additionally, we know that women over age 40 are at significant risk for maternal mortality. Finally, there's an almost twofold increase in maternal morbidity and mortality in this country as compared to the more recent data in years prior. We know that the United States is one of the few nations that is still seeing an increase in maternal morbidity and mortality. The best data that we have on maternal deaths in the US comes from the CDC. They publish a regular report called the Vital Signs, and the most recent report in 2019 showed that 30% of maternal mortality occurs during pregnancy, another third 1 week to a year postpartum, and the remaining third occurs within a week of delivery. It's important to note that these are critical numbers, as only approximately 40% of women actually show up for postpartum visits or get postpartum care. So that means a third of our patients are dying at home or outside of the healthcare system. What's even more frightening is the numbers suggest that 2/3 of these deaths are preventable. Additionally, we find from the Vital Signs report that heart disease causes more than a third of the deaths in pregnancy and in the postpartum period. And finally, Black and American Indian women, as well as Alaskan Native women, are 3 times more likely to die from pregnancy-related causes than their white counterparts. Cardiovascular disease is now the leading cause of death in pregnant women and in the postpartum period, with up to 26% of women dying in pregnancy as a result of cardiovascular disease. This amounts to 4.2 deaths per 100,000 live births. It's important to note that of the 4 million pregnancies in this country, that up to 1 to 4% of those pregnancies are affected by cardiovascular disease. And that we're seeing an increase in the rate of maternal death as a result of cardiovascular disease because of 2 primary issues. One, congenital heart disease is on the rise. The truth be told is we're seeing more congenital heart disease in pregnancy because we're doing a better job of managing these patients when they are born with congenital heart disease. And these women then are aging and becoming healthy pregnant women or having pregnancies with their congenital heart disease. Additionally, we're seeing a rise in acquired heart disease. And these disease processes typically tend to be congestive heart disease or heart failure, myocardial infarction, arrhythmias, and aortic dissections. We're one of the few nations seeing a linear increase in cardiovascular disease in pregnancy. In fact, our rate is twice that of most developed nations, including the United Kingdom. What is driving these findings? It's important to consider the risk factors that put women at risk for maternal mortality. There are 4 key risk factors that have been identified that increase a woman's cardiovascular risk and her risk for maternal mortality. The first of which is race and ethnicity, which we'll discuss in more detail. The second is age. Of recent, more women are delaying their fertility to pursue education and other interests. And as a result, we're seeing women having pregnancies later in life when they have other comorbidities or additional risk factors. Additionally, hypertension is a contributor. Hypertension can be considered a consistent risk factor for women who have pre-existing hypertension or chronic hypertension, as well as those who develop hypertension during their pregnancy. And that includes women with gestational hypertension, eclampsia, preeclampsia, and superimposed preeclampsia. Obesity, which is a national epidemic, also contributes to these risks. And finally, other risk factors like a history of preterm delivery, stillbirth, and small for gestational age babies put women at increased cardiovascular risk. This graph shows pictorially the significant difference in maternal mortality between certain ethnic groups. As you can see, Black and non-Hispanic women have a 3 to 4-fold greater risk of dying in pregnancy than white non-Hispanic women. This is also seen in American Indian and Native Alaskan women who are at significant risk for maternal mortality. It's important to understand how ethnicity and race play into these risk factors. We now know that disparities in health are the healthcare crisis of our generation. Structural racism, which includes implicit and explicit bias, has resulted in misdiagnoses and inappropriate treatments. Institutional failures or system-level factors can contribute to poor outcomes. Systemic barriers, including inefficient triage systems, as well as language barriers, can also impact outcomes. Cultural differences in terms of how patients feel about their trust of the system or cultural humility affect how patients approach the healthcare system and can lead to poor outcomes. And then, of course, social determinants of care also impact our risk for maternal mortality. As we all know, decreased resources can lead to less optimal outcomes for our patients. And finally, stressors, or what we call weathering, have a significant impact on maternal outcomes. In fact, a recent article showed that Black women who were foreign-born have a lower rate of preeclampsia than Black African Americans, and that immigrant populations who come to the US start to see a significant increase in their risk of preeclampsia the longer they're here in the United States, which implies that there is a weathering effect, similar to that which we see in those who've suffered with post-traumatic stress. The increased allopathic load and constant stress of racism and structural racism causes poorer outcomes and worse cardiovascular disease. And that risk extends the entire lifetime of the individual. The image that you see on the right is actually taken from a recent New York Times article. That article looked at giving agency, in particular to Black women. It was published as a toolkit to assist women in navigating those conversations with their providers in hopes of overcoming some of the ethnic and racial barriers to care. In addition to ethnicity, there are additional risk factors, as mentioned, that contribute to a woman's cardiovascular risk and risk of maternal death. We know that women over age 40 are at 30 times greater risk of dying during the pregnancy experience than a 20-year-old woman. Hypertensive disorders, in particular those hypertensive disorders that occur early in pregnancy or predate the pregnancy significantly increase a woman's rate of mortality. And in particular, we see a specifically increased risk of myocardial infarction and heart failure, which can be as high as a 13-fold increase for myocardial infarction and an 8-fold greater increase for heart failure. Obesity, especially pre-pregnancy obesity, increases a woman's maternal risk factors as well. And we know that risk is substantially increased if you have moderate to severe obstructive sleep apnea along with your obesity. Finally, we know the presence of one or more of these risk factors should increase a provider's suspicion for a woman's risk for maternal mortality, given that it significantly increases her risk for death during pregnancy. There are a number of changes that occur in the antepartum, intrapartum, and postpartum period that contribute to a woman's risk during pregnancy and also affect the dynamic and kind of hemodynamic changes that accommodate the high volume load that a woman will see during pregnancy. Increased estrogen and progesterone, as well as activation of the renin, angiotensin, and aldosterone system, causes an increase in cardiac output, plasma volume, and a decrease in systemic vascular resistance. This is coupled with a change in the mechanical compression of the inferior vena cava. Typically, as the uterus or the gravid uterus grows in the second and third trimester, it presses on the inferior vena cava and potentially reduces the return of to the right ventricle, causing postural hypotension syndrome. And then there are additional hematologic, coagulation, and metabolic changes that occur during pregnancy. Hematologically, we see intensified erythropoiesis during pregnancy. And in fact, the increase in red blood cell mass can be an increase of 20 to 30%. However, plasma volume also increases, and that increase can be up to 50%, leading to a dilutional anemia typically worsened in the third trimester. For women who have underlying cardiovascular disease, this could lead to a tipping point in their baseline. Increase in thrombogenic factors occurs throughout the pregnancy state. This is coupled with venous stasis and can lead to thromboembolic disease. Finally, pregnancy is a catabolic state leading to increased insulin resistance as well as atherogenic profiles. Women will see significantly elevated cholesterol as well as fatty lipids during pregnancy, which can take months to normalize after pregnancy. This is a great figure which goes over some of the specific changes that occur during pregnancy. It's important to call out some of the changes that occur in cardiac output, heart rate, blood pressure, and plasma volume with regards to the timing. Cardiac output tends to increase throughout pregnancy, specifically during labor and delivery, but you can also see significant increases in that cardiac output in the immediate postpartum period by up to 60 to 80% within that first hour. Heart rate changes are also noted with an increase in the heart rate up to 15 to 20%, also seen in the laboring process, but can decrease up to 5 to 10% within the first 24 hours after delivery and can continue to change during the first 6 weeks. Of particular interest is blood pressure. Blood pressure tends to decrease in nadir in the second trimester, with a subsequent increase in that third trimester. Those women who have pre-existing cardiovascular disease or hypertension may see their blood pressure increase significantly between weeks 28 and 32. Additionally, though, blood pressure continues to increase, and there may be a short window in that first 24 to 48 hours after delivery where blood pressure may look like it's normalizing and then subsequently increase again as we see fluid shifts in days 3 to 6 after delivery. Plasma volume also increases pretty significantly, and there's a massive autotransfusion that happens in the early postpartum period. I think what's also critical to keep in mind is that we don't see a return to normal pregnancy values for sometimes up to 3 to 6 months after delivery. Also very concerning is, again, with some of the changes that we see in the early postpartum period, we see respective worsening of some of those values, including heart rate and blood pressure, in the first few days after delivery, when many women are already at home and outside of the watchful eye of their healthcare providers. There are also structural changes that occur in pregnancy. The heart ventricles have to adapt to the increased plasma volume and load, and as a result, the left ventricular and diastolic volume increases approximately 10%. You also see an increase in the mass of the heart volume, with the left ventricle increasing up to 50% and the right ventricle up to 40% respectively. All of these changes lead to a respective diastolic dysfunction that can be seen in up to 20% of women at term. And this diastolic dysfunction can be associated with dyspnea and exertion in many of these patients. Also important to note is that the structural changes can take up to a year to normalize. This slide really calls out that, again, we see these very dynamic changes occurring in that immediate postpartum period, but that these changes can last up to 3 to 6 months, but well beyond a year before we see normalization of those changes. This brings us to prevention. Understanding that prevention is critical to our ability to mitigate and decrease the risk of poor outcomes in pregnancy and beyond. Early, specialized, multidisciplinary care is essential in improving outcomes. It allows for shared decision-making with the patient. It also allows for anticipatory guidance and evaluating for potential events prior to, so that we can plan appropriately for that experience. This diagram calls out some of the areas of opportunity for planning and anticipation. Pre-pregnancy counseling is critical. It allows us to review medications, assess cardiovascular risk in advance. It also allows for appropriate monitoring and specific disease care plans. Knowing what disease processes we're dealing with and a patient's cardiovascular risk allows us to identify the appropriate mode of delivery, whether vaginal or C-section, the appropriate timing of delivery, as well as whether or not monitoring is necessary before or after delivery. And then finally, identifying these risk factors allow for us to care for the patient in the postpartum period appropriately and identify additional risk factors for long-term care. As we look at risk reduction strategies more closely, we consider preconception as one of the greatest opportunities for identifying and caring for a patient and reducing her risk. It allows us to recognize and manage cardiovascular risk factors. Again, this allows us to look at tools which can identify those patients, and then by using those tools, create evidence-based approaches to and guidelines to their care. Currently, we have 3 cardiovascular assessment tools that are typically used: the CARPEG-2, the World Health Organization, and the Sahara, of which the World Health Organization tool is the only prospectively validated tool. Additionally, preconception counseling is available to our patients with congenital heart disease, with known disease that has either been repaired or otherwise. It allows us to identify those patients who are or are not candidates for pregnancy and to appropriately counsel them to their risk. Additional risk reduction strategies involve looking at patients in the intrapartum and and antepartum period. This is the second probably greatest opportunity for risk reduction and more likely the first point of contact for most of our patients. That's because up to 47% of pregnancies are unintended or unplanned, such that most of our patients are being identified during the antepartum or intrapartum period. Again, these risk assessment tools can be particularly helpful. They allow us to devise treatment plans, as well as plans for the postpartum period and delivery. They further allow us to address the need for high obstetrical care in the appropriate locations with the right team. Finally, it allows for adequate follow-up and allows us to look for those red flags during pregnancy that may be the signs that lead us to identify those patients who need more advanced care or need collaborative care. This diagram is a great resource. It helps us to look at and compare those symptoms that are normal findings in pregnancy to those that may be signs or symptoms of worsening cardiovascular status. It's important to note that so many of the symptoms that we see, signs and symptoms that we see in pregnancy, can overlap the findings of underlying heart disease. And it can be only subtle changes that occur that without the appropriate sensitivity, we can miss opportunities to identify patients who are at significant risk. These red flags help to trigger closer follow-up and identify those who need referral to cardiology or higher levels of care. I'm going to call out just those that are probably the most common things that we see. In particular, it's not unusual to see dizziness in pregnancy. However, when we start to see unprovoked or exertional syncopal episodes in pregnancy, those are red flags that require referral. Additionally, signs like increasing heart rate, as I mentioned before, are normal findings in pregnancy. However, there are extremes that really need to be identified and called out, including persistent heart rate over 120, elevated blood pressures, or even symptomatic low blood pressure. Saturation levels that are low, especially below the 95%. And then additional signs and symptoms like systolic heart murmurs, excessive swelling, wheezing and crackles on lung exam, all are signs and symptoms that may be suggestive of worsening cardiovascular status. Finally, in the postpartum period, there are significant risk reduction strategies that should be considered. It is important to note that, as mentioned, many of our patients are lost to follow-up in the postpartum period. This is our opportunity to remove barriers to access, to raise awareness about the risk, especially in those first few weeks after delivery. Additionally, to identify risk factors that put a woman at risk for long-term cardiovascular disease, including those mentioned before, like placental abruption, stillbirth, hypertensive disorders, gestational diabetes, and preterm delivery. Finally, the postpartum period is an optimal opportunity to look at contraceptive options for patients who may or may not be good candidates for for future pregnancy. This slide just calls out, again, some of the opportunities to look at cardiovascular risk in the postpartum period. As mentioned before, there's opportunity to look at appropriate monitoring intervals, as well as contraception. Contraception can be a complicated issue during the postpartum period for those who have underlying cardiovascular disease. It allows us to use tools like the Center for Disease Control, Prevention, Medical Eligibility criteria for contraception to identify the appropriate contraceptive method for a patient. As well, in the postpartum period, we know that some women are at higher risk for thromboembolic disease. It allows us to identify the right anticoagulation options, as well as long-term planning for those patients when indicated. It's important to note that there are some additional tools that we need to consider for future keys to success in caring for and reducing maternal mortality. Predictive modeling is one of those potential tools. The preeclampsia integrated tool is a great tool for estimating a woman's intrapartum risk and may be one of those predictive models that help us identify those women at risk for mortality. We now know that mortality is really a retrospective assessment. And so it's critically important that we identify morbidity as a proxy to mortality. And these predictive models and modeling allow us to identify those women most at risk and hopefully prevent mortality going forward. Risk-appropriate maternity care is also crucial, making sure women are getting the right care in the right location, addressing those healthcare disparities. Again, much work to be done in this arena in the future. And then assessing that patients are being provided care with the right level of 24/7 care, whether it's anesthesia or obstetrical care. And regionalization, having women cared for in institutions that have all the resources as well as expertise in caring for these women is critical in success. Finally, as we look at the future direction of cardiovascular care in women, we know that pregnancy heart teams and cardio-obstetric teams are crucial to improving outcomes. A recent study on a single institution in New York looked at cardio-obstetric teams and improved outcomes in a very complex group of patients. Even with those who were diverse with low insurance, they looked at readmission rates at 30, 90 days, and 1 year. And they found improved outcomes in patients cared for by a cardio-obstetric team, including an anesthesiologist, pharmacist, a maternal fetal specialist, and the like. Additional work needs to be done in the area of pregnancy registries. These registries will allow us to look at long-term outcomes and collect data around these women at highest risk. And finally, we continue to need further work and research on these predictive modeling tools as we get better at identifying those women at risk and identifying those morbid conditions that increase a woman's risk. We hopefully will be able to identify those women and prevent them from going on to further complications and mortality during the perinatal window. Thank you for your time. There are additional resources available and supplements in the handouts available at the end of this presentation. Thank you.